The topic for today's morning is anemia in children, tips for everyday practice. So this will be a very simple everyday sort of scenario talk. So I'll start by asking you, at what age should iron supplements be started in full term, normal birth weight, exclusively breastfed well baby? So, absolutely well children coming to the OPD, no concerns. So should they be given iron or not? And what's the answer? So as per American Academy of Pediatrics, the answer is 4 months, but some say 4 to 6. So all normal babies with normal birth weight must be started on iron at 4 to 6 months of age. And this is the dose, 1 milligram per kilo per day. And the question is for how long? And this is what it says: until appropriate iron containing complementary foods are introduced in the diet. So I'll come later on as to what exactly this means. So definition of anemia in children. So these are standard World Health Organization definitions across various age groups. Although we are pediatricians, but I think it's still hard to remember the normal hemoglobin. So from 6 months to 5 years, the normal average hemoglobin is 12. And WHO defines anemia as less than 11. In the age group of 5 to 12, it's 13 and anemia is less than 11.5. And so on, you can see. So what I would like to show you is that although we don't deal with 14 to 19-year-old children, the normal hemoglobin, let's say for a boy in the age group of 14 to 19 is 15, which is hard to remember, that it can even be 15. The normal average hemoglobin is 15, and the definition of anemia is less than 13. So anybody, let's say a boy in the age group of 15 years with a hemoglobin of 12.5 is said to have anemia. So it's good to provide age-appropriate normative data in the Coulter report, but I think it's often not there because I think the age of the child typically does not get entered in the Coulter report, but it's always nice to inform your pathologist that the date of birth should be entered if possible so that the appropriate normative data can be generated. Otherwise, it can be very hard to know what normal is while sitting in the OPD. So now, why is iron deficiency important? And I'll come in the next slide why I have put this in the brackets. So we all know iron has got major effect on neurodevelopment, growth, and immunity. And what clinically you see in the OPD is its association with pica, breath holding spells, febrile seizures. So there is not absolute evidence, but there is a significant association with all of them. Restless leg syndrome, defects in leukocyte function. We all know it leads to reduced exercise capacity. And in neurology, when kids come with stroke, iron deficiency anemia is an important cause. Reason is not known, possibly thrombocytosis. So what is the difference between iron deficiency anemia and iron deficiency alone, that is without anemia? And why is it being discussed? So it's fairly common sense. The ferritin is low in both. So the cutoff is 15. So anything less than 15 is iron deficiency. So obviously in anemia, your hemoglobin is low, whereas in iron deficiency, the hemoglobin is normal. So basically, one also needs to think that iron deficiency is a biochemical iron deficiency without anemia. And why is this important? Because low IQ scores have been observed in iron deficient children even before the development of anemia. So when you have children coming with anemia at the age of 7, 8, 9 months, one has to remember that the adverse effects have already started at the age of 4, 5 months when they were having iron deficiency without anemia. So this was a study done by 2 MD students, Sudarshan and Dharma, and they looked at iron deficiency as well as anemia in absolutely normal babies in the age group of 3 to 5 months. So what the striking finding is that in the age group of 5 months, iron deficiency was seen in about 1/3 kids. So most of them did not have anemia, which is not surprising because you are not supposed to have nutritional anemia below 6 months of age. So iron deficiency, but was significant at 5 months of age, was found in 36% of children. So the next question is, at what age should iron supplements be started in preterm babies? So you would all be discharging preterm babies from the nursery and NN ward. So the answer is 2 weeks of age. Typically, they all get started on iron at the time of discharge. And this is the dose. In term, it was 1 milligram per kilo per day, and this is 2. The maximum is 15. So they have to be given iron throughout the first year unless they are given supplements or fortified formula. So if they are breastfed, they have to be given iron. So now let's look at the prevalence of anemia in the country, because that's really important. So when we are talking about this, we are talking of anemia in the age group of 6 months to 5 years. And in this age, as per WHO definition, anemia is defined as below 11. So it's the National Family Health Survey which looks at this. So this is 2015-16, so about 10 years ago, and it's a huge number, 59%. It's an unbelievable number. So that means if you're in your OPD, if you see 10 kids, about 6 of them will have anemia. And what has happened over the years? So this is more recent, about 2020. This has actually increased to 67%, by about 8%. So it's unbelievable that the prevalence of anemia is actually going up. So the same thing, looking at various states. So anemia 6 months to 5 years defined as below 11. So this is 2005, 2015, 2019. So you can go through the various states. In most of the states, the number are the same or they're increasing. Like, you can look at, let's say, Delhi, 57, more or less same, 60, increased to 69. If you look at Chandigarh, it's dropped a little bit from 73 to 55. So, so huge numbers. West Bengal, Rajasthan, big numbers, above 60, 70%. Some more states, you can look at these various states and see that the numbers are really huge all over the country. And this does get reported off and on in the media, that the number of children with anemia is actually increasing than before. So National Family Health Survey was criticized as not being a very robust survey. So they took finger prick blood rather than a venous sample. So some people do not believe that the National Family Health Survey results are that robust. So this was a survey, a comprehensive national nutrition survey, a really robust, strong survey done in 2016-18. So a large number of children all over the country. So from 1 to 9, then from 10 to 19 years, huge number. So they used a sign-meth hemoglobin method as compared to this photometer method, which was done in the NFHS. And they also looked at the specific etiology of the anemia. Like they performed these iron studies, folate, B12, and CRP. Why CRP? Because the ferritin can be high because of infection. So whenever CRP was high, they kind of excluded them. So this is a very sort of eye-opener slide. So this is iron deficiency, not just anemia, biochemical iron deficiency in the age group of 1 to 4 years. So if you look at India, it's 32%. So in the age group of 1 to 4 years, about 1/3 children will have iron deficiency. And the maximum numbers are in Punjab, Haryana, and this is iron deficiency proven, about 60% or so. The lowest are seen in, states like Andhra, Goa, Assam, and Mizoram. So what is the prevalence of anemia in children in the developed countries as compared to India? Is it same throughout the world or is it more common in India? So this is from the WHO data. They reported this is from the website from 2019. So USA is 6%, Australia is 13%, UK is 16%, China is 19%, and this is the number that WHO has given for India. So why is nutritional anemia more prevalent in India as compared to the Western world? And the answer is that we love to feed our kids milk, wheat or rice-based diets. So, what are the foods which contain iron? So, palak, sarson ka saag, methi, all the pulses, the chole, chana, soya bean, tofu, which is hardly eaten, peanuts, and jaggery. So how much amount of these foods a baby or a child actually eats? Of course, the non-vegetarian foods contain much more iron, and it has a better bioavailability. But because of cultural and religious reasons, many parents in India would not want to give non-vegetarian food to their children. And not only this, foods like milk, curd, tea, and even the pulses and wheat, they contain phytins and tannins, which reduce the absorption of iron. So they contain less iron, and they also reduce the bioavailability is also less. So, you saw in Punjab and Haryana, the iron deficiency anemia was the maximum, and it's largely because they are the milk production is really high. So this question is really important, and all of you should know this answer, that in the age group of 1 to 5 years, milk consumption should not be more than so much ml per day. So when you're sitting in the OPD and you ask dietary history ki doodh kitna peete ho, so you should also know ki kitna peena chahiye. So the answer is 600 ml, which basically means about 2 cups per day. So any child in the age group of 1 to 5 years should not be given more than 2 cups of milk per day. And it's because if you give more milk, then the appetite reduces, the solid food intake reduces. So it's also said that for children more than 1 year of age, if they are still bottle fed, then discontinuation of bottle will help reduce milk intake and increase the intake of other foods. It's because it's very easy to give a bottle. It's comfortable for the mom, it's comfortable for the baby. They just keep on sucking at the bottle. So if you have to reduce milk intake, an important thing is to stop bottle feeding. So we had a talk on urinary tract infection a few days ago by Dr. Kara, and she mentioned that constipation was an important cause for urinary tract infection. So typically constipation, is seen in the age group of about 9 months to 3 years when you're in the OPD. And one of the most common reasons is excessive milk intake. So when there is excessive milk intake, it leads to constipation. This leads to anemia, and it can also lead on to UTI. So just simple dietary knowledge can reduce your iron deficiency. It can reduce your constipation and urinary tract infection. What about overweight and obese children and their prevalence of iron deficiency? Are they more predisposed or are they less predisposed? So the answer is they are actually more predisposed to iron deficiency, and various reasons are given. They have a higher iron requirement. They have inflammation, because of which there is functional iron deficiency, and there is reduced response to oral iron therapy and maybe even reduced iron absorption. So when you see a well-built obese child, it does not mean that the chances of iron deficiency are less. So what is the best iron preparation for treating iron deficiency anemia in children? And thankfully, it continues to be ferrous sulfate, the cheapest and the best. And I guess the problem is that it is cheapest and it is available in government supply, because of which it gets a bad name, because it is so cheap that people tend to think that they need to buy something expensive to get a better iron product. But till date, all standard textbooks, up to date, everything mentions ferrous sulfate as the best iron preparation. The only problem is with the syrup ferrous sulfate. The availability of syrup ferrous sulfate in the market is not that easily available, and it also has a low shelf life. So acceptable alternatives to ferrous sulfate are ferrous fumarate, gluconate, and ascorbate. These are absolutely okay. If you don't get ferrous sulfate, you can use any of these, either in the tablet form or in the syrup form. But many studies have shown that colloidal iron and iron polymaltose complex have a lower efficacy. And colloidal iron is all the preparations of tonoferon that we use, the drops The pediatric syrups and the adult syrup, that is colloidal iron, and that is supposed to have a lower efficacy. So this study was published in IJP in 2019, and they looked at the cost of various liquid iron preparations in the Indian market, and they found that for 100 milligram elemental iron, the cost is varying from as low as about 2 rupees to 200 rupees. So just for the same elemental iron. So their conclusion was that expensive iron preparations are typically marketing gimmicks. So what should be the dose of iron for treatment of iron deficiency anemia in children? So while I was doing my MD, I think Nelson used to say 6 milligram per kilo per day. But now most books would say 3. And the reason is that it has been shown that 3 is as good as 6. So 3 milligram per kilo per day of elemental iron. Whenever you give iron, it's always good to ask the patients to bring back the bottle to you and show. It's extremely difficult to remember how much, which bottle, which preparation contains how much, what is the actual preparation, how much is the elemental. Always good to ask them to show the bottle to you and be sure about it. Earlier, we used to give twice or 3 times a day. Now, efficacy of once daily has been shown to be as good as 3 times per day. So once a daily, 3 milligram per kilo per day. The recent IAP recommendations even say 2 to 3 milligram per kilo. And once daily is enough, preferably between meals, because absorption is better on empty stomach. And duration, 2 additional months after hemoglobin is normal, at least for about 3 months for the treatment of iron deficiency. So some common things that you encounter. While receiving iron, the child develops URI or loose stools. Should I withhold the iron? So very often when you write iron and the family comes back after a month, you ask them whether they are taking iron. They say कि नहीं उसको बुखार हो गया था इसलिए हमने बंद कर दी. So, and many of us also think that iron has association with infections. So the answer is do not stop iron for intercurrent minor ailments. And this is because there is no evidence that iron supplementation increases the risk of infection. The only exception is regions where malaria is endemic during high transmission seasons in some African countries, not relevant for India. So there is no evidence that iron increases the risk of infections. When you have a septic child admitted in the ward, there is really no need to give iron, but at the time of discharge, you can always start them on iron. So another common problem that we see is the GI adverse effects of iron. So the question is, what should I inform the parents regarding the GI adverse effects of iron in children? So answer is very simple, avoid highlighting GI adverse effects. And there is a scientific basis for this, that they have done placebo-controlled trials. They have given placebo versus iron, and they have demonstrated that iron at 3 milligram per kg rarely causes GI symptoms. Often the mothers would correlate it to their own antenatal period of taking iron, resulting in constipation or pain abdomen or diarrhea, and they would think that the child would get it as well. So you can just tell them कि बच्चों में iron से कोई पेट दर्द वगैरह नहीं होता. And there are scientific studies to show this. Maybe at 6 milligram per kilo it used to cause, but if you give 3 and if they still complain, you can give it with meals, or you could divide the doses, or you could even give it 3 times a week or 2 times a week, if it is so much concerning. So the next big question is, when you see a normal child or a child with minor complaints in the OPD, should iron supplements be prescribed? When a child comes with URI to the OPD, he is 4 years old, 5 years old, 7 years old, should you be giving iron? So what's the answer? So the answer comes from this program called the Intensified National Iron Plus Initiative, run by the Government of India under the aegis of National Health Mission and the Poshan Abhiyan. So you could get a short note on this in your exam. So if you leave this hall remembering just one sentence, it's just good enough. So every child should be on iron all the time. Every child should be on iron all the time. So what are the guidelines of National Iron Plus Initiative? So in the age group of 6 months to 5 years, iron has to be given twice a week on fixed days, let's say Monday, Friday, or whatever you like. And this is the dose which is recommended. In the age group of 5 to 9 years, it's to be given once a week. And this is the tablet size. In 5 to 10, it's 45 milligram elemental along with folic acid. and in 10 to 19, it's 100 milligram elemental iron. Along with this, one has to deworm twice a year. So question is, will the parents ever be willing to take iron for so long? So the answer is that iron deficiency in India is a huge problem. I think we have just closed our eyes to it. The prevalence is increasing. Children are not symptomatic because hemoglobin of 8, 9, 10 is hardly does anything to the child, at least apparently. And so what has to be explained to oneself and to the parents is that it is not a medicine, it is a supplement, it is something which is lacking in the food, and you are just giving it. So do not think of iron folic acid as a medicine, but something which is lacking in our Indian diet, because it's mainly a carbohydrate and a milk-based diet. And it's just for 5 to 19 years old, it's just once a week. Until 5 years, it's just twice a week. So one has to just make it a habit. Most of us don't do it, and the children continue to be anemic, so that's fine too, because we have accepted it for so many years, and that's the way it is. So, and this often keeps on getting highlighted in the newspapers that there are several programs running, but somehow the implementation is obviously suboptimal, and that is why the prevalence is increasing. So now the government of India has it even has an online platform wherein the implementation of this program can be checked. So this is for October, December 2022, percentage of children in this age, 6 months to 5 years, provided iron folic acid. So for India, the implementation of this program is about 33%. So as compared to 100 kids, we should be getting only 1/3 are getting. And I've just selected a few states. It's so low. Look at this, like in UP, Chandigarh, Delhi, it's only 1 to 2% implementation. It's highest in Haryana, Telangana, but in many states the implementation is very, very poor of this program. So how to ensure compliance? I think it's not very difficult if you tell the parents that, look, iron has got to do with IQ, particularly in young children below 1 year, below 2 years of age, they should be compliant. And if one has to really scientifically look at it, so iron deficiency has been known to be associated with low IQ scores, but it has not been conclusively proven that iron supplementation will have positive effects on the neurodevelopment. But then there are various reasons given for this, that maybe it's a chronic iron deficiency in utero because of maternal low iron stores and early infancy, and you start giving iron late. Maybe the doses are too low for insufficient periods, and there is the studies which have been done, they lack the power. So taking iron regularly is more important than the brand. After giving this talk, I'm often asked that I use this brand, is it good enough? Should I use this brand? Should I use this brand? So, taking iron regularly is much more important than the brand. Because even if you use a brand which has a lower bioavailability, it will at least have some bioavailability. So giving it regularly is more important. Some other minor things that one talks about while writing the prescription: rinse mouth to avoid teeth stains for syrups. And the other thing which is written is that one can alternatively use a syringe and so that the iron syrup can be given at the back of the mouth to avoid teeth staining. So milk, dairy products should be avoided for 1 hour before and 2 hours after each dose, because it reduces iron absorption. And same thing for calcium syrups as well. So the other question which is asked is that, we talk about such a massive prevalence of iron, of anemia in our kids. So are the hemoglobins cutoff really correct? Maybe that's our hemoglobins are low, and maybe the hemoglobin cutoffs are not really correct for us. So this is an amazing study performed by this group and published in Lancet Global Health in 2021 with a huge impact factor. So this was discussed in a journal club in this hall. So they looked at hemoglobin thresholds to define anemia in this age group in India. So what they did is they took about 50,000 kids and they did large number of tests in them to exclude all common causes of anemia, like ferritin, B12, folate, hemoglobin electrophoresis to rule out all hemoglobinopathies, CRP. Anytime the CRP was high, they would exclude because then the ferritin would go up. And this number, finally, from this number, they came down to a number of 8,000. And what they found is that the study cutoffs for hemoglobin were lower at all ages, usually by about 1 to 2 gram %. More so in the age group of 1 to 2 years and for girls above 10 years. And by this definition of hemoglobin, the anemia prevalence was found to be about 20% lower than the WHO cutoffs. So, question is, what does one do with this? So, I mean, just to go over this again. So, for example, in the age group of 1 to 2 years, the WHO definition is less than 11, whereas in this study, the definition was around, you can see about 9 to 9.5. In the age group of about 15 years, the WHO definition, depending on whether it's a girl or boy, is this, and it was lower for this study. So the conclusion was that the findings support the re-examination of WHO hemoglobin cutoffs to define anemia in the country. You know what, even if you think that this is a correct report, then your prevalence will come down by 20% of anemia. So maybe it's not 60, it's 40. So it's still a huge number. And there is quite a bit of criticism for this study as well. Not everybody is convinced. So I guess time will tell whether, because if you go to WHO website, they say world over standard cutoffs for hemoglobin. Whereas this study says that maybe it's less by about 1 to 2 in India. So I guess time will decide. And the other new information is that the next study of the National Family Health Survey 6 is not going to include measurement of anemia. It's going to be done by a different survey called the Diet and Biomarkers Survey by the National Institute of Nutrition, Hyderabad. And I don't know what is the reason, but they are going to be taking venous blood this time, and they're going to have a smaller sample size. It's going to be less number of children, but kind of a more robust study. So when you give iron to your kids in the OPD, most will respond, but some will not. So what are the causes of failure of iron in deficiency anemia? So the most common will continue to be excessive milk intake and poor compliance. The milk intake has to reduce, the compliance has to be improved. Many times when you ask the parents in the OPD, kitni shishiyan iron ki pilai, and they will even struggle to answer. So of course, most of us now know celiac disease. About 10-15 years ago, this was less commonly known. Now many children with celiac disease actually come diagnosed with outside with a serology in their bunch of investigations. Then of course you have to think of thalassemia minor, and if the ferritin is low and iron does not help, then you have to look at blood loss in the gut and the lungs and ask for a stool occult blood. So low ferritin, not responding to iron, think of blood loss. So how common is celiac disease in India? So this was a large study done in healthy adults in 2016. So they looked at autoantibodies. So in Haryana, it's 1.2. And they randomly picked up 3 states, the wheat-eating Haryana, and then more rice, Assam, and mainly rice, Tamil Nadu. So 1.2 in Haryana, Assam is 0.9, and Tamil Nadu is 0.1. So in children, the numbers are similar. So if you're in the OPD, out of 100 kids that you see, 1 will have celiac disease. So are there any indications to use parenteral iron in everyday practice? It's got a very limited role. The important thing to remember is that the response is not more rapid. About 15-20 years ago, it was used quite commonly in practice. Children coming with pica, they would give a single shot of iron. But thankfully, that practice has reduced and most now give oral iron. But these are the specific indication: inflammatory bowel disease, bowel resection. So the skin condition, epidermolysis bullosa, because the skin sheds off, shedding of the iron. So heart failure is kind of a unique indication, because heart failure leads to mucosal edema and reduced absorption of iron. So less common causes like IRIDA, and an indication which is often abused rather than used is poor tolerability to oral iron, which I said that if you use 2 to 3 milligram per kilo per day, maybe with meals, this should hopefully not be a problem. But if you have to use, there are several iron preparations now in the market which can be given conveniently. Anaphylaxis is rare but can be seen. So other thing which I would like to talk about is delayed umbilical cord clamping. It has got significant reference for anemia, and this has been endorsed both by WHO and the Anemia Mukt Bharat. So WHO says umbilical cord should not be clamped earlier than 1 minute after birth, both for term and preterm infants, except for kids who require positive pressure ventilation, because then you need to possibly take them to the station and do the resuscitation. So what advantages have been shown? That it reduces iron deficiency anemia in infancy, and it may have favorable neurodevelopmental outcome. So I think this is an extremely important step to be done, because particularly the adverse effects on neurocognition are seen in early infancy. So this could give an added store of iron to the babies. It increases the chances of neonatal jaundice and increases the requirement of phototherapy, but in none it has been shown to increase the risk of exchange transfusion or lead on to kernicterus. So what about B12 and folate deficiency? So these have been well reported by the same comprehensive National Nutrition Survey, which looked at all the deficiencies. So you can see across the age groups, so B12 varies from about 14 to 30% and folate from about 20 to 30%. So these are the number for B12 and folate deficiency in normal Indian children. So what is the normal MCV in kids? So when you look at a Coulter report, please look at the MCV. Please look at the MCV. So again, it can be a little hard to remember, but it's at about 1 year of age, it's about 70 to 90 and goes up to about 80 to 100 as the kid grows older. So anything less than about 70 to 80 is a low MCV, and anything which is more than 90 to 100 is a high MCV. So this is important to remember, because you have to decide whether it's a microcytic anemia or a macrocytic anemia. So two common causes of anemia with low MCV, you would all know, is iron deficiency and thalassemia. And when we say thalassemia, it includes both. So remember that minor, trait, and carrier are synonyms. They mean the same thing. And thalassemia major would have low MCV as well. So in iron deficiency anemia, your hemoglobin is low, your MCV is low, your RDW is high, and platelet count may or may not be elevated. So all of you should know this. You can easily diagnose iron deficiency anemia from a simple Coulter report. You may not need a peripheral smear in most cases. So serum iron studies are not necessary, because the prevalence in India is so high that you really need not do any iron studies, and therapeutic trial of iron can be used to confirm your diagnosis. So how many of us in this auditorium have thalassemia minor? So what is the national prevalence? It's about 3.3%. So let's say if you are about 100, it's likely that 3 of us in this hall have thalassemia minor. So why is it important to know? And or before that, so can you look at a Coulter report and tell whether it is thalassemia trait or is it iron deficiency anemia? So this is really important. I know that you talk about those Menzer indexes and they all come in MCQs, but when you're sitting in the OPD, it's really hard to remember those ratios. So in both of them, hemoglobin will be low, MCV will be low, RDW tends to be higher in iron deficiency anemia, but that can be confusing. So just look at the RBC count. In iron deficiency anemia, low iron, low RBCs. Whereas in beta thalassemia trait, it's a dyserythropoietic anemia. So RBC count is high. So low hemoglobin, low MCV, with a raised RBC count is likely to be a thal trait. With a low RBC count is likely to be iron deficiency. And how to confirm? Ask for a hemoglobin HPLC. HbA2 more than 3.5% confirms thalassemia trait. So, in the clinic, we often give them the examples of these Bollywood celebrities to show that they all have thalassemia minor, just to tell that, it's asymptomatic, it's not a disease, but they need to remember that when both parents have thalassemia minor, there's 25% risk of thalassemia major in each pregnancy. So this is the most important, that of the couple, if one of them has it, it's not of a concern. If both have it, 25% risk in each pregnancy. So every pregnant woman must have thalassemia screening done in the first trimester. I think this should be done all over India, but more commonly in the states which have a higher prevalence, like Punjab, Haryana, Delhi, Gujarat, West Bengal, Northeast, because they have hemoglobin E there, but all over India, thalassemia is seen. And antenatal diagnosis can be offered at 10 to 12 weeks with chorionic villus sampling, and the cost is not much. So this is again extremely important thing, that all of us must have our thalassemia screening done to know whether we are traits or not. And beta thalassemia major, typically presents after 4 to 6 months of age. So typically iron deficiency anemia and beta thalassemia major, they will all present after 4 to 6 months of age. This is with hepatosplenomegaly, growth failure, later on hemolytic facies. So this is a thalassemia daycare of the APC, wherein about 25 to 30 kids receive blood transfusion on a daily basis. So because diseases like thalassemia and diabetes are lifelong diseases, one just cannot say that, okay, go to an endocrinologist or go to a hematologist. You should know the basic rules of management of common diseases of every specialty. It is not that, we often get told कि जब हम बताते हैं कि PGI से इलाज चल रहा है तो फिर हमें वो देखते नहीं है. It should not be such thing. So simple 3 rules for management of thalassemia major. Number 1 is to keep the pre-transfusion hemoglobin more than 10. So one doesn't have to transfuse them when they turn anemic. One has to give them blood when the hemoglobin is nearly normal. So as per Thalassemia International Federation guidelines, this should be the pre-transfusion hemoglobin. We are often told that civil hospital the medical officer told us कि जब तक HB 7-8 नहीं हो जाएगा तब तक हम blood नहीं चढ़ाएंगे. So the hemoglobin has to be above 10, 9.5 or so, and one has to give them blood. Second, blood is a necessary evil. Iron will get accumulated. So one has to give them iron chelating drugs to keep the ferritin below 1000. So hemoglobin above 10, pre-transfusion, ferritin below 1000. And third, just to remember, is to encourage bone marrow transplant at an early age because it's curative. Giving blood, giving regular iron chelation lifelong is a tough challenge. So what role can you play in the diagnosis and prevention of thalassemia? Reinforce, encourage at every visit of all thalassemia patients and even your friends, colleagues, that they should have screening done for thalassemia and they should be aware of antenatal diagnosis if both the couples have thalassemia minor. And what are the common errors that we see for blood transfusion in thalassemia major? When, a few patients get blood here, but majority would get peripheral in the civil hospitals, in the state medical colleges. So once you leave PGI and you work in the periphery, you should be aware of this. So first, as I told you, not transfusing blood if hemoglobin is not low. So you have to keep a good pre-transfusion hemoglobin. Otherwise, the growth of the child will not be good. Second, waiting to let blood unit attain room temperature before transfusion. This is something which we used to follow about 10, 15 years ago, that when the blood used to come from the blood bank, try to warm it up, bring it to room temperature. But for a child who has a hemoglobin of 8, 9, and you're giving him blood, this is just not required. The basic rule is that any blood which is released from the blood bank has to be transfused within 4 hours after the release from the blood bank. That's a basic rule. You can't keep a blood unit beyond 4 hours after it's released from the blood bank. So you can start as soon as you get it from the blood bank. It is not an exchange transfusion that you're going to turn the child hypothermic. So please start blood as soon as you get it. Again, transfusing blood too slowly is a common problem with THALs. So any kid who is above 30 kilos will get 2 units of blood because the dose is 15 to 20 ml per kilo. So blood is a drug. You have to chart it in terms of ml per kilo. So the dose is 15 to 20. So anybody above 30 kilos should get 2 units of blood. My understanding is that in adults, the dose of blood transfusion is at least 2 units. No adult should be getting a single unit of packed red cells. They should all be getting 2 units. So for kids above 30 kilos, if their hemoglobin is not very low, one should be giving them 2 units, and 2 units can be given over a period of 4 to 5 hours. And there is really no point in using Lasix for every transfusion unless the hemoglobin is 3, 4, 5 when you have a risk of congestive heart failure. Otherwise, a poor child will be peeing in the evening. And of all the iron chelating drugs that you know of, there are 3: deferriprone, desferal, and deferazirox. The most commonly used is deferazirox. If you can prescribe anticonvulsant drugs, you should also know how to prescribe iron chelating drugs. The most common is deferazirox. It's oral, given once a day. That's the dose. You have to monitor ALT, AST, and creatinine monthly. And the drug is held if the OTPT is about more than 5 times upper limit of normal, typically about 200. And the cost has really come down. For most brands, it would be less than 2,000 for about a 20, 30 kg child. And for generics, it would even be lower. So please know how to prescribe deferazirox for children with thalassemics and not to send them to hematologist for monitoring of deferazirox. So quickly talking about the causes of raised MCV and anemia, and you would know this. So megaloblastic anemia, so always look at the MCV in your Coulter report. So megaloblastic anemia, B12 folate, children if they're on anticonvulsants. So the neurologist would tell us whether they are typically giving folic acid while they are giving phenytoin or not. Any condition in which there is reticulocytosis will lead to raised MCV because retics are large red cells, they are young red cells. And even hypothyroidism is kind of reported to result in raised MCV, but I'm not really sure if it's clinically seen or not. So other things which residents often fear is hemolytic anemia. How to work up hemolytic anemia. So first, when to think of it clinically. So what is a triad? Triad is really simple. Anemia, indirect hyperbil, and splenomegaly. Simple. I mean, this you would all know, that you have to think of hemolytic anemia when these three are present. And believe me, often mistakes are done. We get many kids with this triad who are, who get referred by gastroenterologist after doing an endoscopy, simply because one has not noticed that the jaundice is indirect and not direct. And with anemia, jaundice and splenomegaly, they would think of EHPVO or cirrhosis or whatever and do an endoscopy. So just please look at the simple thing of jaundice, whether it is direct or indirect. So if you have to learn about hemolytic anemia in one slide, you get a child with anemia, splenomegaly, indirect jaundice. So this is what it is. Always talk to your pathologist, ask him to look at the smear and reticulocyte count. Retic count in a Coulter report is often not very reliable, and a manual retic count is more reliable. Then ask yourself, is the anemia episodic or is it chronic? If it is episodic, likely to be G6PD or autoimmune hemolytic anemia. They come to the emergency with a 2-3 days or a few hours history. So it could be either of these two. It could even be malaria or snake envenomation, if they really come with hemoglobinuria and things like that. But episodic, think of G6PD and autoimmune. Autoimmune is easily to diagnose because the moment you send your cross-match, they will say there is difficulty in cross-match. So if it is chronic, coming with days, weeks, months history, next question is, ask yourself, is the retic high or is the retic normal? When we say retic high, I mean like really high, more than 10, 15, 20%. So raised retic hemolytic anemia is hereditary spherocytosis, autoimmune hemolytic anemia, which can be chronic at times, pyruvate kinase deficiency, and unstable hemoglobin. And normal retic is beta thal, HBH is alpha thal, and rarely congenital dyserythropoietic anemia. So remember that in thalassemia, residents often make this mistake. In thalassemia, retic, as per Nelson, is written as slightly low, normal, or slightly high. And why it is not very high? Because it's a dyserythropoietic anemia. And what is the meaning of dyserythropoietic anemia? It means that the red cells are formed in the marrow, but they don't spill over into the peripheral smear. So the retic is not high in thalassemia. And I think I'm finishing soon. So other important thing when you struggle with the differential diagnosis of hepatosplenomegaly is always ask yourself, is fever truly documented or not? If you can answer this, half your DDs will just vanish. Because if you definitely have fever, it's there on the chart, then you think of infections, malignancies, or autoimmune diseases. Whereas if there is no fever, only then you will think of hemolytic anemia and storage disorders. Do not think of thalassemia if there is definitive fever. We often see that in the exam, residents give all the possible differential diagnoses and leave the examiners to decide what the patient has. So you should be able to, you should at least be able to decide between these two whether the patient has fever or not. And for hereditary spherocytosis, you should know that there is this relatively new test, no longer new now, called the EMA, which is eosin 5-melamide test, which is a flow cytometry based test. It binds to the transmembrane band 3 protein, which is disrupted in HS and leads to low reduction in fluorescence. It's a simple, rapid, sensitive. Abroad, the books claim that this test has completely replaced osmotic fragility test. Our lab likes to do both OFT as well as the EMA test for the diagnosis of hereditary spherocytosis. And increasingly now, NGS is being used to diagnose difficult cases of hemolytic anemia. Our lab consultant now tells us that for difficult cases of hemolytic anemia, she would prefer doing NGS upfront rather than doing too many biochemical tests, because this can actually be more cost effective. And pyruvate kinase deficiency is hard to diagnose by a biochemical test, and the diagnosis is more often made easily by an NGS. So always remember that the causes of anemia below 6 months of age are different from children above 6 months. It is not very common to get kids below 6 months with anemia, but these are the causes. And always remember that deficiency anemia as well as thalassemia is uncommon below 6 months of age. Thalassemia because that HbF transition takes place, and iron deficiency because you have some maternal stores. So it's typically above the age of 4 to 6 months that you see iron deficiency or thalassemia. So these are the causes: blood loss, isoimmunization, this is fairly common, AB or RH, malaria becoming less common. So you can have congenital dyserythropoietic anemia or pure red cell aplasia in this age group. So below 6 months of age, no hepatosplenomegaly, think of pure red cell aplasia. So I'm ending here by concluding that iron deficiency anemia is rampant in children in India. Rather, the prevalence is increasing. The national program implementation is suboptimal. So all of us as pediatricians in any specialty have this responsibility of implementing the guidelines of this Iron Plus Initiative program on a one-to-one basis in our OPD practice. Otherwise, the prevalence is going to continue to be high. And we must encourage thalassemia screening in all of us. Thank you.